Dear colleagues, dear friends, it is my great honor to give a presentation here. My topic is the value and consideration of microwave ablation in the treatment of thyroid nodules. Part 1. About us. I was from a territory university hospital from Shanghai. The hospital was founded in 1910. And in 2016, we established a Shanghai Center for Thyroid Disease in our hospital. And in our hospital, we performed ultrasound-guided intervention procedures, including thermal ablation, about 800 cases per year, and FNA plus gene test about 5,000 cases per year. We have published several important articles in the thyroid areas, including the Journal of Radiology, JCM, and Thyroid. And also, we have been included in a panel of Wu-Feng thyroid guidelines about the thyroid ultrasound elastography. Also, we have developed thermal ablation for thyroid tumors guidelines as a chair. Part 2. Microwave ablation in thyroid. This is the principle of microwave ablation. When a microwave tunnel inserted in the tissue, the microwave will be output, and the molecule of water will be highly excited and lead to high-speed movement, and movement will lead to friction, heat, and when the temperature is above 60 centimeters, the tissue will become coagulation necrosis. The first microwave ablation in thyroid was published in 2012, and after that, in 2013, a large sample size thyroid benign nodule treatment with microwave was published, and then the malignant thyroid tumor was published in 2014, and then the metastatic thyroid malignance treated with microwave was published in 2015. The ablation techniques, including hydrodisection, we can inject some waters or saline to linear thyroid, which can avoid damage to adjacent critical structures, such as the nerve, the muscle, and the critical vessels. And then ablation technique include the trans-isthmic approach. From the isthmic approach, we avoid damage to the nerves, and also it will lead to easy compression after the treatment to avoid the bleeding. And this is the diagram of the trans-isthmic approach. And we usually perform the ablation with the transverse plane. And for some nodules, with hypervascularity, we usually first perform the capsule ablation to avoid the bleeding from the nodule. And when performed microwave ablation, we usually using the moving shot techniques. Moving shot. When we perform microwave ablation, we ablate one point and then pull out the needle, and then another point, and then another angle or another plane. And this is the example. Firstly, the deep side of the nodule, and then the superficial side of the nodule. And this is after treatment, the nodule becomes small. And also for large tumors, we usually perform the ablation layer by layer. First point, and then line, and then plane, and then develop a plane. And for very large tumor or tumor adjacent to some critical structures, adjacent critical structures, we usually perform ablation in different stages to avoid the possible complications. For example, this is a very large lesion. Firstly, we perform the first session, and after several months, the lesion shrinked, and then we can perform the second session of microwave ablation. After ablation, we usually perform instant treatment response evaluation. We usually use the contrast enhanced ultrasound to perform a treatment response evaluation. And when the lesion is totally ablated, there is no enhancement in the lesion. And this is the pre-treatment, and then this is the post-treatment figure. For with regard to the treatment efficacy for benign nodules, we can see that the volume reduction ratio is about 90% 2 years after treatment, and there is 93% after 3 years. And the complication rate is very low. For papillary thyroid carcinoma, we can see that after treatment, about 84% lesions were disappeared after treatment. This is some articles about the comparison between radiofrequency ablation and microwave ablation. And we can see that both the systems are suitable for treating thyroid nodules and show no significant difference in the duration of application, energy transmission, and volume reduction. However, microwave ablation requires less shots to treat the whole nodule. This is the illustration of different shapes and sizes of some ablation zones in thyroid. This is the cold IF electrode. And this is the microwave. ablation. And with regard to the comparison between radiofrequency ablation, microablation, and HIFE, you can see that radiofrequency showed a significant volume reduction of nodules of 50, and microwave ablation of 44, and a HIFE of 48, and radiofrequency ablation, microablation, and HIFE showed comparable results considering volume reduction. All methods are safe and effective treatment of benign thyroid nodules. And this is another article compared surgery and microablation for benign tumors. And we can see that a significant difference was found between the two groups in levels of CRP, IL-6, and TNF-alpha after operation, and there was significant difference between the two groups in intraoperative blood loss, operation time, post-operative hospitalization time, and post-operative complication rate. And these four figures show the operation time, blood loss, complication rate, and hospitalization of microwave ablation and traditional surgery. And this figure shows the serum concentrations of CRP in microwave and conventional surgery. And this figure shows the post-treatment after surgery, and this figure shows the post-treatment figure after a microwave ablation. And this is another prospective long randomized cohort study, including microablation and traditional surgery. And in this study, microablation shows acceptable and promising efficacy compared with thyroid dichotomy. Microablation was associated with less trauma and comparable complication rate. And this is another study compared the result of surgery and microablation for papillary thyroid microcarcinoma. And this study shows that mean length of stay, cost, mean blood loss, and surgical incision OR time, and complication in the microwave group was significantly lower than those of the surgery group, and the quality of life after microablation was higher than it was after surgery. The low recurrence and metastasis occurred in either group during the follow-up period. And this figure shows the hospitalization cost and the quality of life and others. This is the complication rate. We can see that complication rate of surgery was significantly higher than that of microwave ablation. Opinions from related guidelines. For the career, this is the career guidelines released in 2012, which indicates that thermal ablation may be an alternative to surgery in patients with benign thyroid nodules. And this is the ATA guidelines published in 2015, which indicated that thermal ablation may be most useful in high-risk surgical patients or in patients refusing additional surgery, rather than a standard alternative to surgical resection of metastatic disease. And this is an ACE/AME guidelines released in 2016, which indicate that ultrasound-guided thermal ablation treatment may be considered for solid or mixed symptomatic benign thyroid nodules. And this is the Korean guidelines published in 2017. So, in these guidelines, thermal ablation was proposed for primary thyroid cancers and follicular neoplasm. In 2020, and the European Thyroid Association published guidelines for benign thyroid nodules, which indicated that in adult patients with benign thyroid nodules that caused prior symptoms or cosmetic concerns and decline surgery, ablation should be considered. Based on direct comparison studies, the balance between efficacy and the side effects, thermal ablation are recommended as the first-line treatment modalities, and microablation should be at present be considered second-line thermal ablation procedures. And this is a recent guidelines published by European Thyroid Association, which indicate that thermal ablation can be considered in patients with DTC in the following conditions, such as PTMC, unresectable thyroid cancer, and the leg lymph node recurrence of DTC and distant metastasis. This is the indications for the use of thermal ablation in papillary thyroid microcarcinoma. So these are the factors favoring thermal ablation, including the demographics, cytology, and ultrasound examination, and the technical resources. And these are the factors favoring surgery. Such as subcapsular location, posterior location, peritracheal location, multinodular goiter, and extrathyroidal spread. Part 4, the work of our team. And this is the study compared the efficacy of radiofrequency ablation and microablation for benign nodules. We can find that the volume reduction ratio, therapeutic success rate, symptom and cosmetic score, and complications related to treatment for the two techniques are equivalent. And IFA and microwave ablation are both effective and safe methods in treating benign thyroid nodules. This is the inclusion criteria and exclusion criteria of the study. This is the patient in IF group, and this is the patients in the microwave group, and finally 2,060 patients were included. And this is the ultrasound assessment after the treatment. This is the baseline characteristics of patients with thyroid nodules treated with microwave and radiofrequency ablation before and after matching. This is before matching, and this is after matching. You can see the low significant difference between the two groups. And this is the treatment results in propensity matched population of patients with thyroid nodules. We can see that the volume reduction ratio at 12 months, and there was no significant difference. And also the secondary endpoints such as the symptom score, cosmetic score, therapeutic success rate, and symptom and major complications. This is a case of radiofrequency ablation pre-treatment and 12 months after treatment. This is another patient treated with microwave ablation. This is the pre-treatment imaging, and this is the post-treatment imaging after 6 months after ablation, microwave ablation. So microablation and radiofrequency ablation are both effective and safe methods in treating benign thyroid nodules. And this is a comment from a group from Korea, which indicated that this is the first study comparing two some ablation modalities, and the authors reported valuable results and used the standard techniques. This is another study from our group, which used the microwave ablation to treat low-risk papillary thyroid microcarcinoma with a long-term follow-up. The follow-up duration was about 37 months, and after the treatment, 94% got complete remission, and only one patient was detected with systemic lymph node metastasis, and a low distant metastasis was observed, and a low delayed complication was associated with microwave ablation. This is a pre-treatment study. And this is the study. This is the image shows that the lesion showed complete remission after 6 months after microwave ablation. And our results are indexed or referenced in some guidelines, including the German guideline, the Wu-Feng guideline for thyroid nodule treatment, and the Korean guideline, and the Italy guideline, and also American textbook, a comprehensive guide for the clinician. Australian guidelines also cited our results, and this is the European Thyroid Association guidelines cited some of our results, and this is the recent European Thyroid Association guidelines for malignant thyroid lesions. And we will also received the Best Abstract Award in the 2007 Interventionist Oncology Congress, and also the first prize winner of Asia Pacific Congress of Interventional Oncology. In summary, microablation achieved promising results in both benign and malignant thyroid lesions. The disease progression after microablation for malignant thyroid lesions remains challenging. More prospective studies with a rare design are necessary to provide more solid evidence. Thank you very much for your attention.
Thank you. That was a fantastic talk. We really thoroughly enjoyed it. I'll just open the house to any questions. If any questions have been asked on the message boards.
Yes, we've got a couple of questions. Does a PET scan should be done before ablation? Have you ever met any lymphostasis after node ablation?
对不起，再重复一下，我这地方可能比较吵一点。
好的。
So I think.
Let me repeat the question. Does PET scan should be done before ablation? Have you ever met any lymphostasis after node ablation?
Lymph node metastasis? You mean?
Yeah.
For malignance?
I think so. They just mentioned
if
PET
the
scan.
patient have lymph node metastasis, we usually do not perform microablation, unless the patient refuse to go to perform surgery. So the pre-treatment examination is very important. We have to exclude lymph node metastasis before the treatment.
So do we need to do PET scan before the thyroid nodule ablation?
Usually we do not need PET CT scan, but it's for benign nodules, there's no surgery, no necessary. This is not necessary. But for malignant lesion, maybe sometimes we perform CT to scan the leg. And usually PET CT is not performed.
Okay, Dr. Ahmad, do you have any question?
I think that was an excellent talk, and to summarize, I mean, it's a modality used for both benign thyroid nodules and for malignant. So I think that question was very specific about malignant nodules, and like you said, Professor Xu, I think if it has metastasized, then you've missed the boat, and really you shouldn't be doing ablation. So I completely agree, and I think that was thank you very much for clarifying that. Are there any particular malignant lesions that you preferably target? You touched on it briefly, but and do you treat parathyroid adenomas as well? It's slightly outside the scope of this talk. But.
Yeah. For in fact, we were very cautious to perform microablation for malignance. We usually perform microablation in those lesions with small size. Usually, it must be less than 1 centimeter, and usually it is not located in near the capsule of the thyroid. And yes, sometimes we perform microablation for parathyroid nodules.
And one other question, you mentioned about doing capsule ablation to avoid bleeding. Could you explain that a little bit more?
Yeah, I think it is an important procedure because thyroid is very hypervascular sometimes. So if you want to avoid bleeding, you must ablate the lead tract first. So we usually before we ablate the nodule, when we insert the leader, we usually ablate the capsule for several seconds. Only several seconds is enough, or maybe 3 to 5 seconds to ablate the capsule, and then we can insert the needle into the nodule. It is not a long time ablation, because for example, you perform ablation or several millimeters in the nodule. Beneath the capsule will be obscured. You cannot clearly see the nodule. So only several seconds is enough.
And do you always use contrast enhanced ultrasound to monitor the ablation zone or the effect of the ablation response?
Yes, that's sure. It's sure. Every patient we perform contrast enhanced ultrasound before ablation, and then after ablation. Yeah, we usually 2 times. Yeah. If the nodule shows viable tissue after the first ablation, we must to perform the second to achieve the complete ablation.
So I think we've had questions from the audience via text. I've asked a few questions. Is there anybody amongst the faculty, anybody else who wants to ask any questions?
Excuse me? How many volume reduction from the text? Yeah, for benign nodules, we usually need to perform get a volume reduction rate above 50%. That you mean that a technical success means volume reduction ratio above 50%. In fact, we almost perform complete ablation for all the nodules. Yeah, that's very important, I think.